Good evening, everyone. We are going to discuss medical history taking or how to take history from a patient. Um, it's according to the expectations of MCC during your neck OSCE exam. The expectation is that you are structured, you're efficient, you finish on time, you do not waste time, you do not go overtime, you do not finish too early, and that you're exam ready or you know what you're doing during the station. First, history taking structure. Medical history, history of surgical diseases, medical diseases, symptoms in general. This is going to have these components. First component is chief complaint. What is bothering the patient? What is causing the patient concern enough to come to the clinic or the hospital? History of present illness. This is going to be the second part that we are going to elicit or ask questions from the patient and elicit the history of present illness. So it includes the duration, character, etc. You would use the OPQRST or old cards or OCD PQRST structure, whichever structure you're comfortable with, and figure out what is causing the patient's chief complaint. Now, remember one thing, if patient has 3 symptoms, for symptom, I'm going to use SX as a abbreviation. So 3 symptoms, ask about what started first. So symptom exploration goes chronologically. First, second, and then third. If patient can first felt or first started coughing, then started feeling having a fever and now is bringing up sputum, explore the cough, then the fever, and then the sputum. Or you will explore these in history of present illness using the structure that you're most comfortable with. Now, review of systems or symptoms in if you're working in hospital or if anyone here who has worked in surgical residency, especially in review of systems, you asked about all systems. But since in exam, you will have a very limited time, usually 4 or 8 minutes, ask about relevant findings. In general, we would want you to cover at least the constitutional symptoms for all patients and then come to the relevant findings. If patient has chest pain, ask about relevant things like shortness of breath, palpitations, history of acid reflux, things that are going to yield positive or negative findings. Past medical history, again, this is extremely important. Patient who has, for example, a chest pain, you have to ask about their past medical history and see if they have diabetes, hypertension, dyslipidemia. Uh, make sure that they have or they don't have any risk factors for developing acute coronary syndrome. Family history, again, this is going to reveal important information, particularly in conditions like diabetes, hypertension, heart disease, where family history matters. Positive family history increases the likelihood of patient having the same condition. Also in certain cancers like breast cancer. Yes, Dr. Sneha?
Dr. Fans, the lecture is not being recorded.
Oh, I started recording. It is recording. It's recording. Okay, so we can continue. Family history. Like I said already, it's important. Make sure you do not miss important family history. For example, if someone has chest pain, ask them if anyone in the family had heart disease, like or a heart attack. This will give you an idea of what the patient may be having. Social history. In social history, they usually want you to cover alcohol, drugs, smoking, and depending on the presentation, sexual habits, safety, etc. These are some of the things that you cover in social history, their living situation, their economic condition. These are something that you would cover for patients, especially if they are psychiatric patients. Now, remember for history taking, I have here that never skip and never mix order. Go follow this order: 1, 2, 3, 4, 5, 6. Chief complaint, ask what's bringing them in, explore the symptoms, review systems, ask past history, past medical history, family history, and social history. Go in order so that you don't miss. If you are asking chief complaint and then coming straight to past medical history, I'm going to stop you right there, because you're going to miss things and then you will have a totally different diagnosis than what the patient is presenting with. Now, chief complaint. What is the chief complaint? It is something that brings the patient in. Why is the patient here? Are they having any pain? Are they suffering from a cough? Are they having any fever? Are they here because they're concerned? This is where you would anchor your entire history taking. So chief complaint, why is the patient coming in here for? In chief complaint, the rule is that you use patient's own words. I have chest pain, and then you follow that up. So chest pain, ask how long has it been going on? 2 days. I also have a cough. How long? 3 days. Okay, so the cough started first, explore the cough, then the chest pain. Keep the chief complaint short and precise. Ask about chief complaint and the duration. If there are multiple chief complaints, then go chronologically. Start with the one that started first and then come to the one that started now. Do not interrupt the patient. Do not diagnose just by the chief complaint. Go take your full history before you say you have pneumonia. Chronologically, you would ask question. And earliest symptom should be explored first, like I said multiple times now. History of present illness. Now here, what we are going to do here, we are going to dive deep into the chief complaint. Most marks can be scored here. So if you are careful with your HPI or your history of present illness, you're going to score most of your points. And if you're not, you're going to lose most of your points. Follow chronologically, have a logical order or flow, and question or to ask or explore symptoms, start open-ended questions, and then narrow down if it's not going anywhere. Use the structure OCD, PQR, STUV, AA systematically. We are going to discuss what the structure is and how you can use it. If you have another structure, some people use OPQR, STUV, that is also fine. Some people use old cards, particularly I think Kiki Medics, they also use old cards. That's fine. Finally, link the symptoms to the patient's function and the severity and how it is impacting the patient's life and what they are expecting from you. Patient may say, I have the chest pain is stopping me from working or from doing sports that I love. So make sure you address those concerns too. Now, once you're done with the, now the OCD PQR STUA, the structure for the OCD PQR STUVA, I recommend that you follow it rigidly, and then as things come up, you will adjust it to the patient. From the rigid means that you follow the structure OCD PQR STUV in order. If something comes or if the patient says it's been ongoing for the past 3 weeks, so they already gave you the time or the duration, you don't need to re-ask that question. So you will adjust it as the patient goes. But you have to follow the order for other things. Now, onset, this is extremely important. Almost always start with the onset. When did your problem or your concern or your complaint or your pain or your fever start? This will help you in knowing if this is something acute and could be emergent or something that has been chronic. is less likely to be emergent, but may have worsened and could be still emergent. And onset also helps in narrowing down differentials. Let's say a patient has chest pain. Now, for chest pain, you have multiple systems. Could be from the lungs, from the heart, from the muscles, musculoskeletal chest pain, or it could be from the abdomen or the stomach or GI. Each one would have a different type of onset. For example, chest pain that is pulmonary embolism or a pneumothorax, it will start within a few seconds and reach maximum intensity or severity within seconds to minutes. Chest pain that are more towards GI, they will have a pattern of recurrence. And this is how these questioning or this onset or asking about when did it start is going to help you when you are exploring chest pains or any other symptom. Now, in onset, I want you to ask three things. When was the first time the symptom started? What was the patient doing when it started? Coronary syndrome or acute coronary syndromes, STEMI, NSTEMI, unstable angina, and other anginas, they usually start when the patient is exerting themselves. Emotional exertion, physical exertion, eating a big meal, stress, any of these can trigger it. Now, if you ask the patient, when did your chest pain start? And they say 40 minutes ago. Oh, I'm so sorry. What were you doing when it started? They would say, oh, I was shoveling snow. I was doing this. I was doing that. I was eating. I was at a barbecue. I was at a buffet and I ate a lot of food or I ate a heavy meal. These are some of the triggers for acute coronary syndromes and patients who already have blocked arteries, right? Finally, ask if the pain was felt all of a sudden or they just started feeling a discomfort that gradually got into an ache and pain and then now it's getting unbearable. Sudden pain, like I said, that starts in seconds to minutes and gets to the full intensity in a few minutes is usually concerning for embolisms or for pneumothoraxes when you are talking about chest pain. Course, or some people say the C stands for character. However, you are comfortable. I prefer keeping it separate from duration. So course, I use course. How has the pain been behaving since it started? For chest pain, if it is angina, patient rests for 5 to 10 minutes, it resolves. But if it is acute coronary syndrome, the pain is going to be ongoing and staying the same or worsening. It wouldn't get any better. So ask the patient directly, is the pain or is the chest pain getting better, getting worse, or is it the same as it when started? Duration. Now, some symptoms may not be consistently present. For example, in angina, pain comes and goes, comes and goes. Ask about the duration. How long does the symptom start once it starts? This will help you in identifying if something is episodic or something that's been ongoing for a while. For example, if a patient has stable angina, they will feel pain on exertion that resolves in 5 to 10 minutes, usually less than 15 minutes. But if the patient is having episode of unstable angina or an MI, it's not going to resolve in 5 to 10 minutes. It's going to stay consistently for a long time. And again, in the duration, if patient says it's been ongoing for 30 minutes, or I have had this symptom for a long time, ask them if it is present all the time or if it is comes and goes. So this will help you in determining if the patient's condition is persistent or if it is something that is triggered, resolves, and then again is triggered by something. Now, fourth letter that we use is we covered O, we covered C, we have covered D, we are going to cover P or position. Where is the pain? Chest pain it has a broad differential, like we said already. But if it is originating from cardiac, it's usually felt behind the sternum. Patient is unable to pinpoint it. They would say, I have pain here. And the pain would be going somewhere else, for example, the arm, the jaw. Again, once you ask about where the pain is, ask about if there is any particular position that helps or makes it worse. For example, patient who has chest pain that gets better when they get forward or bent forward. This could point towards pericarditis instead of a STEMI. Chest pain that is worse by getting upright or taking a chill breath. This could be pleurisy or something different than a STEMI. So ask about where it is located and how does positioning affect the pain. Quality or character, what does it feel like? Ask the patient, what does your chest pain feel like? They will say, it feels like someone is sitting on my heart or my chest, or someone is squeezing it, someone is burning it, someone is stabbing me, any of that character. But if they say, I don't know, ask them specifically, does it feel like squeezing, turning, or pressure, or does it feel like a sharp pain? This is going to help in differentiating acute coronary syndrome from other causes. Coronary syndromes, angina, MIs, etc. The pain is pressure, squeezing like in nature. But for GI symptoms, musculoskeletal, the pain is usually sharp. Once again, I would like to add here, just because the usual is sharp for GI doesn't mean that coronary syndrome may not present with sharp chest pain, okay? Now, the sixth thing that we're going to cover about in the OCD-PQR is the R, or radiation. Is the pain going or shooting anywhere else? Ask it as it is. This is the easiest way to ask. Is the pain going anywhere else or shooting anywhere else? If chest pain is radiating to the left arm, to the jaw, this is concerning for acute coronary syndrome. If someone has a crushing chest pain that is radiating to the back, then that becomes concerning for aortic dissection. Severity, how bad is the symptom or how severe is your symptom? You can also use the 1 to 10 system. For chest pain that is due to MI, usually it is ischemic pain, and ischemic pains are 10 out of 10. Most patients would say it's a 10 out of 10 or even higher. Some patients may say it's 8 out of 10, but it would be a very severe pain. Now, key timing or time course or any particular altering between the pain, for example, ask them if the symptom is worse at one specific time of the day. This helps down in narrowing down our differentials. This is important, but sometimes it's not appropriate to us. For example, if someone comes and says, my chest pain has been ongoing for the past 30 minutes, and you're asking them what time of the day is it the worst, that's inappropriate. It's irrelevant. It's not answerable because the patient doesn't know it started 30 minutes ago. All right, so chest pain, episodic chest pain that starts towards the midnight or early morning. It could be prinzmetal angina, which is common in women, and they find relief with nitroglycerin because it's because of spasms of the coronaries. U stands for understanding. What does the patient think is going on? Most patients, they have an idea of what their condition may be. Some would outright say, I don't know. But others would say, I think it may be my heart. It will also ease the burden of having to explain to the patient that they're having a heart attack on you. If they already think they're having a heart attack and you find that they're having a heart attack, it would be easier to communicate to them. But if you don't ask their understanding and their expectation, then it would be something that you would have to restart from the beginning. Again, V or the letter V in our OCD structure. It stands for value and déjà vu. Now, value, what does the patient want? And déjà vu, we want to know if they have had episodes like this in the past. Patients with coronary plaques who get stable angina episodes on exertion, they can suddenly have a rupture of those plaques and have an acute MI. So if someone has a chest pain and you don't ask if they had it in the past, you may miss that they have a history of chronic angina, which was stable, but now could be an acute myocardial infarction. Now we come to the three A's in our structure. Aggravating factors, what makes it worse? Chest pain that is worse on exertion is concerning for cardiac causes, acute coronary syndromes particularly. Alleviating factors, what makes it better? Chest pain that gets better with rest, with nitroglycerin. These are specific for angina. Myocardial infarction, chest pain usually does not get better without interventions. We will discuss what interventions we can do for patient with acute coronary syndrome. Finally, the last A of the structure is associated symptoms. Now, depending on the above, you can ask relevant questions here. And we have in this structure, I want you to make sure that you are covering important things. Like if someone has chest pain, I would ask them relevant questions like feeling lightheaded, feeling dizzy, feeling diaphoresis, about things that could be palpitations that could be associated with MI. Cover red flag symptoms here and associated symptoms that are going to point towards a specific diagnosis. Now, this is a practical breakdown of an HPI. For HPI, do not treat it as a checklist. Make it an actual natural conversation. Do not sound like a robot questioning patient. Usually, if you ask onset and progression first, this builds the timeline and helps the patient start trusting you. And character, quality, etc. These are the things that you ask about to maintain the flow of the conversation, modifiers, aggravation, etc. And then impact on the patient or patient's perspective. These are the things that you go and ask. Follow this, follow the OCD structure, modify it as you go along. Make sure that once you are done, you finish with associated symptoms and you summarize to the patient. You presented with chest pain that started 1 hour ago when you were taking, you were shoveling your driveway, and it has been ongoing since then. You haven't found any relief with resting. It concerned you that you may be having a heart attack. That's why you called the ambulance, and ambulance brought you in. Kind of like a story, and then at the end, ask them if you missed any details. Now, review of systems. In the associated symptoms, you can ask relevant symptoms. If the associated symptoms, you don't want to do it that way, you can then ask review of systems or do a full review of systems. But in general, we would want you to cover the general or constitutional, which are fever, weight loss, appetite, fatigue, night sweats. Now, if patient is coming in for 30 minutes of chest pain, are they going to have any weight loss? I doubt they will. Appetite, fatigue, these would become irrelevant. So you can just ask if they're having any fever. This will help in differentiating pneumonia from cardiac or other causes. Cardiac, for cardiovascular, ask chest pain, palpitations, edema, respiratory, cough, shortness of breath, wheezing, etc. GI, pain, nausea, vomiting, diarrhea, constipation, changes in stool, blood in stool. These are some of the symptoms you can ask. Now, for chest pain, once I'm done with the associated symptoms like dizziness, palpitations, etc., I'm going to cover GI too, because GI is one of the most common causes of chest pain. Peptic ulcers, pancreatitis, a lot of things that can present with the upper abdomen or lower chest pain. All right. neuro symptoms that you need to cover in some patients would be headache, weakness, syncope. So syncope would be relevant here to this patient since they're having chest pain. Now, once you're done with review of systems, come to your past medical history. For one thing that I would like to add here is the transitions. When you're doing review of systems, tell the patient that you're going to ask them questions about other systems or questions about their some symptoms that they may be feeling, let them know if any exist. And then you're going to transition to past medical history by saying, I'm going to ask you about your past medical history or your health in general. This will help me get to my diagnosis better or help narrow down the diagnosis for me. Use the structure ample. If you have another one, some people use sample. I don't mind using any of them. You can use any of these structures. A is for allergies. Ask if they're allergic to anything. If someone is allergic to aspirin and they're having acute coronary syndrome, you cannot give them aspirin because you're going to get them into anaphylactic shock. Medications that they are currently taking, past illnesses and surgeries, and then last hospitalization, last menstrual period in women of reproductive age, last meal in surgical cases and in emergencies, because last meal is going to change our management if someone needs a surgical treatment or if someone has an emergency. E would be environmental exposures or events that led to the symptom. Again, environmental exposure is important in symptoms that are usually long-term or prolonged. Chest pain that started 30 minutes ago, I don't think there is any environmental factor other than smoke inhalation that can cause acute chest pains. But if there are, make sure that you cover them. All right. Now, family history, it's very important for chest pains. Ask about cardiac disease, strokes, diabetes, cancers, hereditary conditions. Yes, you can ask, especially if you're worried that the patient may also have aortic dissection. It doesn't happen without trauma in normal people. If it happens in someone without trauma, think of something like Marfan, which is again genetic or hereditary condition, or Ehlers-Danlos. These are something that can cause aortic dissection without trauma. Now, if someone is deceased, like father or mother, empathize, tell the patient that you're sorry for their loss or you're sorry to hear about their passing, and ask about why and when did they die and how old they were. And treat this like patterns, not like a list. So make sure if you're asking about early cardiac disease, don't just tick mark, make sure you connect it to your patient. Social history. Now, social history is extremely important. Canada focuses on social history a lot. And it's one of the things that we can control to prolong life in most people. Smoking, alcohol. If you ask about smoking and they say yes, make sure you ask about how many packs and for how many years. And mention if they have ever considered or if there is anything that would motivate them to quit. Alcohol, ask about type. For example, beer, some people say beer or consider beer as alcohol, others don't. Beer, whiskey, vodka, whatever they are drinking, it all have different types of, different concentration of alcohol that you can qualify simply into two groups like hard liquor and beer. So hard liquor is something that has more alcohol content, quantity of the alcohol, frequency. Now, alcohol and smoking, these are extremely important for chest pain. Smoking increases the risk of coronary syndromes. Alcohol can cause cardiomyopathy. It also increases the risk of coronary syndrome. Drugs, amphetamines, cocaine, stimulants in general, they can increase myocardial demand by increasing heart rate or causing tachycardia. And then patient will have type 2 ischemic heart disease or demand ischemia. Occupation, we can ask about occupation. Stress plays an important role in inducing just anginas or chest pain. So if you're asking about occupation, make sure you ask if it's very stressful environment, living situations. This is very important in the elderly and psychiatric patients in general. So don't miss it in those patients. In acute chest pain, when you're worried about coronary syndrome, you can defer it to be asked later on. Sexual history. Um, this is not usually relevant to acute coronary syndromes. Once again, if patient has chest pain that's been ongoing for a while and they're having low-grade fever with tiredness, or in short, I'm referring to endocarditis, you can ask about sexual history and IV drug use. IV drug use puts a patient at risk of developing bacterial endocarditis. Now, to put it together, your flow should be confident and efficient. Make sure that you are asking the questions like a physician would, and not like a student who is nervous and mumbling their words. Speak loud, not too loud, but with confident. Speak with confidence. Speak clear and concise. Do not over explain things that are simple, and do not use medical jargons. And remember, the patient feels your professionalism when you are structured and showing empathy on time and doing everything well. Now, again, start open-ended, then structured. Once again, do not say you're having chest pain and then no. Let the patient tell you they have chest pain. Start with a broad question. What brings you in? I'm having chest pain. I'm sorry to hear about your chest pain. When did it start? Started 30 minutes ago. Don't say, did it start in the past 1 hour? They will say yes or no. It's irrelevant. It's not going to give you good information. Good information comes from when you let the patient speak their mind. Do not jump between sections. Cover chief complaints, then HPI, then associated symptoms and review of systems, then past medical history, then family history, then social history. Don't go to family history and come back to symptoms. I'm going to stop you during practice right where you do this. And at the end, make sure that you summarize to the patient. If there is any inconsistency, clarify with the patient early on before you take a full history, and then you have to clarify no. If the patient tells you their pain started half an hour ago, but then they mention it was there for a few weeks, clarify what do they mean by it. Is it the same pain that they were having for a week? Is it worse than that? This could give you critical information about what to do next. Some of the common mistakes that IMGs do. Timeline in HPI. How long have the symptoms been going on? Asking review of system questions randomly. Go systematically. Go system by system if you're not sure. Cover all the systems. If you know what symptoms you are going to get positive and negative, just cover those. Ignoring patient concerns, understanding or what they value or what they want, missing medications and allergies. Some medications can increase your risk of getting heart disease or coronary syndromes. Amphetamines are prescribed widely for ADHD, and they can cause or they can increase the chance of someone having tachycardia, and then from the tachycardia, because of the demand, they can have chest pain because the heart is not getting enough oxygen. And finally, if you're not asking about severity, it means that you don't care about the patient's or perception of the pain or what they are doing, they're feeling right now. OSCE tips, have an exam mindset. It says not casual clinic, but I would say think like a physician who is in a clinic. Don't think like these are your casual patients, think like you're seeing them for the first time. Be systematic, because when you are pressured and you're not organized, you're going to make mistakes. Stay systematic, stay organized. You will very unlikely for you to make mistakes. But if you are jumping back and forth and you're already stressed out and you're sweating, it's going to be hard. Once again, if you are going to change sections or transition, make sure that you let the patient know that you're transitioning to something. If you're going to ask about past medical history, say, I'm going to ask about your past health. And remember to use patient language, not jargon. Do not say it looks like acute coronary syndrome. Say, I feel like you may have heart attack. Good thing is you came just in time, so we can do something about it. So make sure you provide patient information that is accurate, plus reassurance in the same sentence. Don't let them worry to death and then tell them that, oh, we can do a stent and it should help. Do not interrupt patient in general. If they are speaking, let them speak. Red flags, these are to be asked always. You cannot miss red flags. If you miss red flags, it's going to cost 2 points. And again, close with summary. Make sure it is accurate. Check with the patient if information is accurate that you got, and if there is anything that they may want to add. All right, this is the basic history taking and what is expected of IMGs to do when they're taking history from a patient in NACOST.